Welcome to PGOG postgraduate class in obstetrics and gynecology for postgraduates as well as consultants of obs-gynae. Today's topic is etiopathogenesis of hypertension in pregnancy. It is a somewhat theoretical topic and difficult to reproduce. So I will try to make it as reproducible as possible. Now, there are four underlying risk factors for development of hypertension in pregnancy, such as exposure to chorionic villi for the first time, abundance of chorionic villi, pre-existing endothelial cell activation or inflammation, and genetic predisposition for hypertension in pregnancy. Now, when we read the textbook and when we read these underlying four factors, usually we can remember one or two, but it is very difficult to reproduce all the four. So, let us make it easier to memorize. And for that, what I find is pictorial memory helps us more. Whenever we draw the small pictures like that, and we have our own way of remembering it by drawing the diagrams, it helps us to memorize. And that is why I have prepared this slide so that it is the reflection of the whatever we have seen in the last slide. Same thing, but it is in pictorial form, especially because it helps us to understand and it helps us to memorize. So what are the underlying risk factors? We know a long list of risk factors whenever we talk about hypertension in pregnancy given in textbooks, such as elderly patient, previous hypertension, diabetes, or primary gravida patient, and patient who has a chronic hypertension, that we know. But we can categorize these risk factors into four categories is given here. First is whenever there is a first time exposure to the placenta, first time exposure to the chorionic villi. And the reason is the placenta is having paternal component, and that is how the uh, mother responds to this paternal component by development of hypertension in pregnancy. So this is first time exposure to the chorionic villi is first time exposure to the placenta. Second is large amount of placental villi, which is seen whenever there is a multifetal pregnancy. Larger placenta is there, so more number of villi, and it will be associated. We always be one of the risk factor for development of hypertension in pregnancy and trophoblastic gestational trophoblastic disease, especially complete vesicular mole. Now, whether a fetus is necessary for development of hypertension in pregnancy, answer is no, because in complete vesicular mole there is no fetus, and still it is one of the high risk factor, most high risk factor for earlier development and severe development of hypertension in pregnancy, and that is why we know that fetus is not necessary for development of hypertension in pregnancy. What is there is mainly the number and first time exposure to the chorionic villi, because in chorionic villi there is also paternal genetic component. Chromosomal contribution is there. Third is if there is already vascular damage is already there in the mother. So it is now it is easy to understand vascular damage, but what is the terminology used is pre-existing endothelial cell activation. So how we remember is we draw a vessel, and the innermost layer of the vessel is endothelium, and endothelial cell activation is synonymous with endothelial cell dysfunction. So whenever endothelial cell damage or inflammation is there, that means there is a vascular disease. So any disease which is associated with damage to the vessels in the body, pre-existing disease, that will be the risk factor, and the most common will be diabetes and chronic hypertension. Last is genetic predisposition. So we remember it by drawing this diagram of the chromosome, and small part of the chromosome is a gene, and multiple genes are involved here for development of hypertension in pregnancy. So that is why we can remember it like this. So my request to postgraduates is whenever we enter into a topic which is more theoretical, but which we need to understand, reproduce, as well as it helps us whenever we are treating the patients, in for such topics it is better to convert the information pictorially and take out the notes like this. This is almost like taking out my own, preparing my own note for whatever I have explained in the last slide. Etiopathogenesis, why hypertension in pregnancy develops, the most still till date in modern obstetrics also what is the first line is, unfortunately still we say that exact mechanism is still not known. And that is the reason there are various theories, out of which for postgraduates most important is a two-stage theory that we should know as well as we should understand. It is especially relevant whenever there is early onset hypertension in pregnancy. Early onset is whenever the hypertension in pregnancy develops before 34 weeks of pregnancy. Now, in this two-stage theory, there are two stages, stage 1 and stage 2. Stage 1 is placental syndrome and stage 2 is maternal syndrome. What is placental syndrome is there is incomplete trophoblastic invasion of spiral arterioles. This is most important sentence and which we need to memorize as well as understand, that there is a incomplete trophoblastic invasion of spiral arterioles, that is placental syndrome. Whereas maternal syndrome is the effect of placental syndrome on mother, on all the systems in the mother. Maternal syndrome is systemic inflammatory response to the this placental syndrome. Where, but what we need to understand is it is a modifiable. This systemic inflammatory response is not uniform or same for all the patients who have placental syndrome. Stage 2, though it is dependent on stage 1, it changes or differs from one patient to the other because it is dependent on pre-existing maternal endothelial activation or inflammation. In other words, some of the women will have a severe form of maternal syndrome, and some of them might be having a non-severe, and that is the reason we have two categories depending on severity of hypertension in pregnancy as severe and non-severe. The reason is it is mainly the difference in the maternal response to placental syndrome depending on how much is the pre-existing maternal vascular damage is present. Same thing in a pictorial way I have tried to demonstrate. Stage 1 is placental syndrome, where there is a defective placentation because of the incomplete trophoblastic invasion of spiral arterioles. With that, it leads to the development of changes in the vessels all over the body, and that leads to stage 2, that is maternal syndrome, which will be affecting all the vital tissues such as heart, liver, brain, kidney, and all the other organs also, as well as tissues. Etiology of hypertension in pregnancy, the theories we can divide in four. First is defective placentation. Second is immunological intolerance. There is an immunological intolerance so that the mother has intolerance for the paternal component in the placenta and fetus. Third is maternal maladjustment to cardiovascular and inflammatory changes in pregnancy. Normal pregnancy has certain changes in the cardiovascular system and inflammatory changes are also there, but normally the mother's body is adjusting with these changes. But if there is a maladjustment, it leads to the development of hypertension. It is a etiological factor and genetic predisposition. Now, to understand the first, that is placental maldevelopment, what is we need to understand is what spiral arterioles, anatomy of spiral arterioles. Now, this is the uterine artery which is sending the branches which are piercing into the myometrium. Then there is another network of arcuate arteries, rich network. Arcuate arteries are again sending radial arteries, and then these are smaller apical arteries are also there, which are again parallel to the junction of endometrium myometrium, and from these vessels, apical vessels, small spiral arterioles are piercing the endometrium, but spiral arterioles, some of the part of spiral arteriole is in the myometrium also. So this is the myometrial part of the spiral arteriole, and the coiled one is the endometrial part of the spiral arteriole. In normal pregnancy, spiral artery remodeling takes place with primary invasion, which is completed by 12 to 13 weeks. And this invasion is by extravillous trophoblasts. These are the trophoblastic cells which are not present in the syncytial or cytotrophoblast. And that is why these are called as extravillous trophoblastic cells. These trophoblastic cells are invading the spiral arteriole, leading to the reduction in muscular and elastic content of the vessel wall. With this, there is a another wave of invasion, that is secondary invasion, which takes place from 15 to 26 weeks of pregnancy, and especially it is of changing the myometrial component of the spiral arteriole. So primary invasion is mainly for the endometrial or decidual component, whereas the secondary invasion is specially changing the vessel wall, which is of the in the myometrial part of the uterus. With this change, the vasculature changes from narrow to wide. It becomes from adrenergic sensitive to adrenergic non-sensitive, and from high resistance, it becomes a low resistance blood flow. So that is why this invasion is very, very important for normal development of placenta. With effective placentation, what is happening is, now here, as we can see, again the invasion of spiral arteriole by extravillous trophoblastic cells. This is a normal spiral arteriole, which is through which the blood is freely flowing here into the intervillous space, and these villi are floating in maternal blood. This is a tertiary villus, which is lined by outermost is syncytiotrophoblasts, then is a cytotrophoblast, and inside we have the fetal vessels inside. Now, what is happening with a defective placentation is there is a spiral arteriole invasion is incomplete. Especially the myometrial component remains constricted, so that even if the opening is wide, the myometrial diameter of the myometrial component of spiral arteriole remains, it is less by around 50% as compared to the opening, and that is the reason there is a high resistance flow, what we say as chronic placental insufficiency. So what is happening here is, why there is an insufficiency is, it is a high resistance flow and blood is not flowing freely here because of the constricted part of the spiral arteriole, which is leading to the development of high resistance flow. This placental syndrome, defective placentation is placental syndrome. It leads to the development of obstetric complications, such as there is a high risk for development of gestational hypertension, preeclampsia, eclampsia syndrome, preterm delivery, intrauterine growth restriction, and abruptio placentae. So these are all complications of placental syndrome, and this hypertension in pregnancy as gestational hypertension or preeclampsia syndrome. These are the uh, one of the complications of placental syndrome. Now, second theory is immunological intolerance. Normally, what is happening in a normal pregnancy is there is a immunological tolerance by suppression of humoral as well as cell-mediated immunity in normal pregnancy. It helps in tolerance for fetal and paternal placental component acceptance. So paternal component is there in the placenta, that is chorionic villi, as well as in the fetus. And because of the suppression of the immunity, there is a tolerance. What is happening exactly is there is a dominance of Th2 cell mediated humoral immune response. That is, Th2 is T helper type 2 cell, whereas there is a suppression of T helper type 1 cell mediated immunity, so that there is suppression of inflammatory immune action by releasing of cytokines. Mainly these Th1 cells, they are leading to cell mediated immunity by mainly by releasing cytokines, and this action is suppressed. So this is normal pregnancy where the action of Th1, Th2 is in balance. But what is happening in pregnancy is Th2 activity is more, Th1 is getting suppressed, and that is why there is a type 2 bias. It is typically called as type 2 immunological bias during pregnancy. What is type 2 bias is Th1 cell cell-mediated immunity is suppressed, whereas humoral immunity is dominant during normal pregnancy. It leads to the immunological tolerance. Points which favor this immunological intolerance theory are: histopathological findings of placenta are suggestive of acute graft rejection in patients with preeclampsia. If you send a placenta for histopathological examination in patients of preeclampsia, the findings are same as those found with a acute graft rejection. So it is placenta is like a graft because it has paternal component also. And whenever there is a graft rejection like finding, it is suggestive of immunological intolerance. Complete mole with diploid paternal chromosomes, it is a higher risk of for hypertension in pregnancy as compared to the partial mole, because there are only paternal chromosomal contribution is there. Diploid paternal chromosomes are present in complete mole. So already there is a exposure to excess villi, and all the villi are having only paternal component, no maternal component is there, and that is why it is a high risk factor for development of hypertension in pregnancy. And this fact suggests that there is a immunological intolerance. Multipara with pregnancy by a new partner or a primigravida is at higher risk for development of hypertension in pregnancy. So whenever there is a first time exposure to paternal antigenic component of placenta and fetus, there is a higher risk. On the other hand, multipara with the same partner have lower risk getting immunized in first pregnancy. So these 2 points also favor the immunological intolerance theory. What is happening in pregnancy is there is increase in cell-mediated immunity, that is Th1 activity increases, and that leads to the loss of type 2 bias. So, this is not normal. There is a balance between Th1, Th2. Then normal pregnancy, there is a dominance of Th2. But again, what is happening in patients of hypertension in pregnancy is Th1 activity increases. So Th1 activity, cell-mediated immunity is covered by gets activated by release of cytokines by T helper 1 cells, and their action is mainly pro-inflammatory and anti-angiogenic. So there is a more of a pro-inflammatory and anti-angiogenic action, and that is how it starts, it initiates the development of hypertension in pregnancy. Next theory is genetic predisposition. Points which favor this theory are: sisters, daughters, or twins of those who already were affected by hypertension in pregnancy, they are at higher risk for development of hypertension in pregnancy. It is not a single gene is not found to be responsible. There are multiple genes, and that is why this hypertension in pregnancy is a polygenic disorder. Phenotypic expression. Now the meaning of this word is phenotypic is how the patient presents. Now we all know that the phenotypic expression has wide spectrum. That is, some patients have severe disease, some patients have non-severe disease, and it is because of the interaction of multiple genes with environmental factors. So this also contributes to favors the genetic predisposition theory, that suppose we have 3-4 patients who are admitted in emergency ward with hypertension in pregnancy. One patient might be having only mild gestational hypertension, will be their non-severe gestational hypertension, and she will deliver and go home without any complications. Another patient might present initially with the same range of blood pressure, but might progress into with a severe disease such as development of HELLP syndrome or development of eclampsia, which might be life-threatening for her. So there is a wide range of phenotypic expression, and this is thought to be because of the interaction of multiple genes with the environmental factors. Stage 2 of this theory is maternal syndrome. It is modifiable by risk factors. That is why the phenotypic expression will differ from patient to patient. Now, these are the 4 components of the maternal syndrome, which are all related to vessels. So remember that basically hypertension in pregnancy is a vasculopathy, which is affecting all the vessels in the body. Though we see only intrauterine growth restriction and we feel that placenta is mainly, placental perfusion is mainly getting affected, placental vessels are mainly getting affected, but we should always, whenever we examine a patient, we should remember that same changes are occurring in all the vessels in the body, so that all the organs, vital organs in the body also are under stress whenever patient has hypertension in pregnancy. So what are the components are? There is a systemic endotheliopathy. This is most important terminology to be remembered by all the postgraduates. Endotheliopathy. There is vasospasm. Vessels are more sensitive to vasopressors, increased sensitivity to vasopressors, and there is dominance of anti-angiogenic factors which are secreted by placenta. We will see one by one what is the meaning of these four terminologies in the maternal syndrome. Systemic endotheliopathy is, now this we can see the vessel, and all the vessels have these layers as intima, media, and externa. Intima, the innermost layer, is formed by the endothelial cells. And when we say endotheliopathy, that means there is a endothelial cell activation or dysfunction. So endothelial cell activation or dysfunction is systemic endotheliopathy, where there is an injury to endothelial cells all over the body. Now, what is the normal function of important function of the endothelial cells or endothelium is it has anticoagulation action. That means it keeps the vessel patent. Till the time endothelial cells are intact, the clot formation is not happening, and that is why the flow in the vessel, blood flow in the vessel remains normal. So that main function of endothelium is to has anticoagulation action. Once the endothelium gets damaged, then the clot formation starts, and that is how the blood vessel might get blocked. Second is it blunts the response of vessel to the vasopressors. It reduces the response of vessel to vasopressors so that vessel doesn't go in spasm easily and blood flow remains intact. Ultimately, most important function of endothelium is to keep the blood flowing in a blood vessel, and these are the two important functions. With the placental syndrome, there is a incomplete trophoblastic invasion of spiral arterioles, and there is a high resistance blood flow in the placenta that leads to the release of placental factors into the blood circulation in the mother. These placental factors have toxic free oxygen radicals. These placental factors are having toxic free oxygen radicals which produce oxidative stress on the endothelium, which leads to endothelial damage. And another action of this oxygen free free oxygen radicals is it leads to vasospasm. So vessel is going in spasm, as well as there is an endothelial damage which leads to the formation of clots, and that leads to thrombocytopenia. And because of the endothelial cell damage, there is an endothelial leak, and the capillary permeability increases. That leads to the shift of the fluid from intravascular compartment to the extravascular compartment, which is leading to the development of edema and proteinuria. So these are the important clinical implications or clinical effects of this systemic endotheliopathy: development of thrombocytopenia, development of edema, and proteinuria. Systemic endothelium, because of this damage to the endothelium all over the body. Endotheliopathy is nothing but damage to the vessels. What is happening is it leads to vasospasm. Vasospasm leads to development of hypertension, and there is a fluid shift from intravascular to extravascular compartment. Both of these two factors, vasospasm and tissue edema, lead to tissue hypoxia, and there is ultimately end organ damage. As in severe cases of maternal syndrome, what we can get is a renal damage, liver damage, heart gets affected, or brain gets affected. Patient can have eclampsia, convulsions. All of this is because of the vasospasm along with tissue edema. With the tissue edema, another effect of this shift of fluid from intravascular to the extravascular compartment is there is a hemoconcentration. Blood which is flowing through the vessels is concentrated. It further, this hemoconcentration itself reduces the tissue perfusion, which affects the kidney function and placental function. And whenever a patient bleeds, even a normal delivery with a normal blood loss also, what we should remember is she is losing more of RBCs because it is the blood which is having a hemo concentration. So these are the clinical effects. Hypertension is there, end organ damage is there, edema is there, and with hemoconcentration, whenever a patient has hemorrhage, she might not be able to even tolerate normal bleeding also, blood loss also, because whatever she is losing is the RBCs, and tissue perfusion is also no, is adversely affected. Systemic endotheliopathy increases the sensitivity of the blood vessels to vasopressors. It is because normally the endothelial cells are secreting prostacyclin, that is PGI2, which is a vasodilator. But whenever there is an endothelial cell damage, there is a reduction in the release of prostacyclin by the endothelial cells. On the other hand, their platelet aggregation takes place here with a small clot formation, and these platelets are secreting more of thromboxane A2, which is a vasoconstrictor. So there is an imbalance between vasodilator and vasoconstrictor, imbalance between PGI2 and thromboxane A2. There is a reduction in PGI2 to thromboxane A2 ratio in patients with hypertension in pregnancy, and this leads to the increased sensitivity of the vessels to vasopressors, such as there is increased sensitivity to angiotensin 2, which is seen. Another reason is these endothelial cells normally are secreting nitric oxide, which is leading to the reduction in the sensitivity of blood vessels to vasopressors. But with endothelial damage, this nitric oxide secretion is reduced, and that leads to, again further, it adds to the increasing sensitivity of blood vessels to vasopressors in patients with hypertension in pregnancy. Placenta is secreting some anti-angiogenic factors as well as angiogenic factors in a normal pregnancy. Angiogenic is the factor which promotes the development of blood vessel. Anti-angiogenic is a factor which hampers the development of new blood vessels. Here in patients with hypertension in pregnancy, there is more of anti-angiogenic factor secretion by placenta that leads, and there is a reduction in angiogenic factors that affects the placental development adversely, leading to defective placentation, systemic endotheliopathy, and all the vicious cycle for development of hypertension in pregnancy. Thank you so much.